Hi, I'm Shelley Wood, the Managing Editor for Heartwire, and my guests here today are Dr. Adnan Kastrati from the German Heart Center in Munich and Dr. Magnus Ohman from Duke. And our topic today is new developments in interventional cardiology. There's been several news trials, interesting trials that have come out at the ESC meeting, and that's our topic for today. We're going to start with the study PRODIGY, which was a look at duration of dual antiplatelet therapy after stenting. And I'm going to hand the torch over to Dr. Kastrati here to just walk us through that.
So I had the chance to be the discussant of this trial. That's why I know the trial in details now. PRODIGY is a trial on optimal duration of dual antiplatelet therapy in patients receiving drug-eluting stents, but has also the peculiarity to have a subgroup of patients with bare metal stents. The authors of this trial wanted to know whether the duration of dual antiplatelet therapy makes a difference between drug-eluting stents and bare metal stents. The trial included 1,970 patients and divided in two groups. One group received only 6 months of dual antiplatelet therapy, and the other group received 1 year. So the main comparison was between 6 months and 1 year. The primary endpoint was an ischemic endpoint. It means it was a combination of death, myocardial infarction, and stroke. And there was also a safety endpoint, which was major bleeding. The strengths of the trial, for me, are that it was an independent trial, not supported by industry, first. Second, it was an all-comer trial, which means that it had the chance to have a lot of patients with acute coronary syndromes. More than 30% of the patients had STEMI, which has not been the case in other trials of this kind. At the end of the story, the trial showed clearly that there is no benefit in reducing ischemic complications by prolonging therapy from 6 months to 12 months. On the other side, which is much more important, it showed that by prolonging therapy you can get more bleeding complications with a significant difference between the two groups. At the end, we can say that on the basis of this data, we are on the safe side if we give only 6 months of dual antiplatelet therapy to patients who receive drug-eluting stents. One of the limitations, you may say that it's the number of patients. 1,970 patients, it's not a large trial. But we have to go back and remember other trials which have a very significant impact on the practice, like CREDO trial. CREDO trial was a trial of 2,000 patients only.
Right.
And you know the impact had by this trial. So I don't think that this is a major limitations. It would have been much better to have more patients, but with this clear result, I expect for this trial to have a certain impact on the practice.
So let me just fit this edgewise here, but of course we are waiting for the huge DAPT trial, which is the major, I believe, how many, 20,000 patients I think they're enrolling in DAPT to look at duration of dual antiplatelet therapy. But from my perspective, I've been interviewing interventional cardiologists for years and saying to them, if you had a drug-eluting stent, how long would you take clopidogrel? And they've almost universally said, I'd take it for life. So on the basis of what we have here from PRODIGY, Dr. Ohman, would you feel confident yourself taking clopidogrel with aspirin just for 6 months, or how long would you want to have that on board?
Well, and I think the challenge here is that, as Adnan said, it's an all-comers trial. And we have really good evidence in the ACS population that 1 year of dual antiplatelet therapy is really a minimum. So it's hard for me to sort of throw out those trials and say, well, you know, because we not only have one trial, we have like 4 or 5 trials, all showing reduction in death and MI and stroke, at least up to 1 year. So I think this trial points to one very important thing, though. It says for other elective type of patients, maybe we need to revisit the duration a little bit. I think the dual antiplatelet trial with 20,000, so we're talking now of the combined trials to date, the small trials, of which PRODIGY is one, we're looking at 6-fold higher patient. And I think that's important to recognize. I think it's important to point out, though, that all those small 3 trials are very consistent. They really no event reduction. They have had a varying signal on bleeding.
Right.
And I think that's even among those interventional cardiologists that you ask, they have been in the back of the mind.
Yeah.
How safe is this? And I think this trial points, probably the best type of trial that's done to date, it points to the question. And I do an antiplatelet therapy trial, which is a large trial, 20,000 patients, will really be very conclusive.
Yes,
Magnus, I think I fully agree that it will not be able to change the practice for acute coronary syndrome patients, but having such a large number of acute coronary patients, you have the reassurance that at least with elective patients, it is safe to shorten therapy.
Mm-hmm.
True, and that's exactly how I set it up.
And the other piece of information we need from this study, and either I missed it or we didn't get it, and that is what type of stents patients were getting and how that tracked with the duration.
There were three kinds of drug-eluting stents and one bare metal stent. So the three kinds of drug-eluting stents were Science, were Endeavor, and Taxus.
Okay.
So because there is a second objective of this trial to look at the differential effect of late lumen loss on the length of therapy, and they chose drug-eluting stents with different late loss.
Okay.
Taxus,
different potency.
Endeavor with more late loss, and Science with much less.
Well, I think we'll let our viewers wait for the paper to get those details, perhaps.
I don't think that you will have the chance to see it because the main paper will be focused on just duration of therapy.
Yes, that could be true.
And this is exactly that. The objective of Marco Vergimilli to have 10 papers with one study. And,
well, that's a noble goal. I'm sure everyone would want the same. Let's move on. The other study I wanted to talk about was the examination study. Now, this was looking at drug-eluting stents again, but in the setting of STEMI. And maybe, Dr. Ohman, you can walk us through examination. Key points.
Key points. So, large STEMI trial, second-generation drug-eluting stent, Science versus bare metal stent.
And that's the key point. We're talking second generation here, not first generation as we had with some of the other earlier studies, Horizon, some of these
right. In the meta-analysis of the first generation stents, no effect on death and MI, no effect on stroke, all significant reduction in target vessel revascularization. And then there was this lingering idea of what about stent thrombosis. Mm-hmm. Now we have this large trial carried out, I think, in an excellent manner by a Spanish group with collaborators, randomized a large number of patients using Science versus cobalt chromium. Identical to the other trials with the first generation, really no effect on death and MI. So very similar. So it doesn't look like, at least in the MI setting, that things change from death and MI. They did show reduction in target vessel revascularization, which was a secondary.
No big surprise, perhaps.
Then. No surprise there. The follow-up was relatively short. It was 1 year. Some of the benefit from the earlier second-generation drug-eluting stent trials is that over time there's a reduction in death and MI, but at least at this 1 year point there was nothing. Tantalizing, but the numbers are very small, was this benefit of stent thrombosis. There was a significant reduction of stent thrombosis in the drug-eluting, so now in the second-generation Science stent versus the cobalt chromium or vision stent.
Right.
That to me was interesting, but the numbers are very small. But it was tantalizing that we may be working in the right direction finally in this setting. I don't know, Adnan, what do you think?
I think it's a good trial. It's the second largest trial on drug-eluting stents in patients with acute myocardial infarction, second after Horizon's Army trial. I agree with all you said. I see only one problem with the trial, the selection of the primary endpoint.
Okay.
By choosing any kind of revascularization, you are not focusing on what you are expecting from drug-eluting stents, because you cannot expect from drug-eluting stents to reduce the number of interventions in other vessels.
I see. Okay.
And that's why the trial at the end had no difference at all for the primary endpoint.
So we may have seen a better result had the primary endpoint been a bit more focused.
Yeah. I think that also the recommendations of ARC are very clear in this direction. Device-specific endpoints with which you can assess the real benefit with drug-eluting stents. But think about patients having more than 50% of them with multivessel disease.
Right.
In some time they will come back to have other vessels, and this dilutes the overall results.
Right.
And at the end, more events came out related to interventions in other vessels than to reinterventions in the target vessel.
That's right. I was going to just touch briefly then. I know there's another trial that's quite close to your heart. Dr. Ohman, do you want to just tell us a little bit about CRISP AMI?
Well, CRISP AMI trial is actually one, I think, what will eventually be a series of trials to try to see how we can improve outcomes in large anterior MIs with different devices and approaches. But this first one is using a very old technology, intra-aortic balloon pumping. Key here was that it needed to be put in before the primary PCI, causing some delay, in fact, in getting primary angioplasty done. Primary endpoint was infarct size by Kodak MRI at 3 to 5 days. No significant difference in MRI infarct size among patients who had a balloon pump put in before primary PCI versus standard of care primary PCI. Tantalizing maybe clinical events during the follow-up period, but the trial at 340 odd patients, it's not large enough to really detect differences in clinical endpoints in this setting. But there was also some crossover, namely the patients who got sick with these anterior MIs actually ended up getting a balloon pump. But having said that, I think it tells us that we need to be vigilant. Patients with large anterior MIs that get sick, they will likely benefit some from a balloon pump. Exactly who they are and how we should look at that strategy in the future remains to be studied.
And just to clarify, is this then confirming something that is already sort of believed to be true, or will this change practice? Are people using these more than they should currently?
I don't think it will change practice. I think balloon pump is actually the second oldest device currently in use, so I don't think people have a pretty good idea when they will use it. There's large international differences in who uses balloon pump and who does not, but I think this won't change practice. It will make just people think a little bit about how vigilant to be to looking for evolving cardiogenic shock.
All right. Well, for people that want details on any of these studies, of course, I would direct them to our heartwire coverage, but I really appreciate you gentlemen sitting with me and sort of fleshing some of those out for me. Thank you both very much.
Thank you, Shelley.
Thank you.